Okay, this is what we call the edge-to-edge repair. The edge-to-edge repair, the so-called Alfieri technique, just because I introduced that in the surgical armamentarium back in 1991, so it's more than 20 years, consists of approximating the edges of the leaflets exactly at the point of regurgitation. You can see here in this particular case, we have a flail of the anterior leaflet, and this insufficiency was corrected with a simple stitch connecting the anterior and the posterior leaflet exactly at the point of regurgitation, creating a double orifice mitral valve. The edge-to-edge technique has been utilized in our hospital in a different percentage. In the beginning, we didn't use that technique so much because we are a little bit reluctant and we wanted to see the long-term results. Later on, when practically minimally invasive surgery started at the beginning of the 2000, between 2000 and 2005, the edge-to-edge technique was used in about 35% of the cases. And later on, our current utilization of this technique in our hospital is about 20% of the cases, so 1 case out of 5. This is what is the valve after the edge-to-edge repair. As you see, you don't see the suture line anymore. You don't see the stitch because endogenous tissue is completely covering the suture that was connecting the two leaflets. This is a heart who was transplanted in a patient who had a severe mitral insufficiency and severe left ventricular dysfunction. The mitral valve was perfectly functioning at the time of transplantation, but of course the patient was in severe heart failure because of severe left ventricular dysfunction. We call this technique a simple solution. So we define this technique a simple solution for complex problems. Obviously, there is nothing simple in life, and there are precise rules to be respected also with this simple technique. And the surgical rules to be respected are listed in this slide. The suture should be limited to the zone of the regurgitant jet. We have to respect symmetry in order to avoid a distortion of the valve. The suture should be kept to the minimum, enough to correct mitral regurgitation, of course, without producing mitral stenosis. The distance of bites from the free edge is variable according to the redundancy of the leaflets. For instance, if we have a Barlow's disease with a very redundant leaflets, we have to stay far away from the free edge in order to reduce the total amount of tissue and avoid the postoperative sum. Then a prosthetic ring to be added when annular dilatation, annulus leaflet mismatch is present. The definition of annular dilatation is a little bit controversial. Anyway, we think that the best definition is a mismatch between the leaflets and the annulus. So when the septolateral dimension, this one here, over the anterior leaflet is more than 1.4, then we can call this annular dilatation. And in these particular circumstances, a prosthetic ring is essential. Anyway, the role of annuloplasty, we think, is very important in mitral valve repair. The annuloplasty has been routinely added to the edge-to-edge procedure to increase leaflet coaptation and stabilize the repair. Absence of annuloplasty is associated with increased stresses on the suture and on the valve structures, And we have been showing that in a three-dimensional computational models together with the bioengineers. Absence of annuloplasty is associated with accelerated failure. You see on the vertical axis freedom from reoperation, and you see that patients with no annuloplasty had a much lower freedom from the reoperation. In other words, they required more reoperation in the future. So let me tell you something about the edge-to-edge technique in conventional surgery and give you an overview. As I told you, the first case was performed in 1991. Now we have more than 3,000 published cases all over the world. The follow-up with a consistent number of patients is about 15 years, although there are many patients who have reached more than 20 years now. Technically simple and reproducible, can be used with a lot of versatility. In other words, can be used in functional mitral regurgitation, can be used in degenerative disease and occasionally in other circumstances, also in rheumatic disease. Has been criticized by many surgeons, but because mainly it was not applied correctly, and by many was used only as a bailout, only in a situation where the patient was in a very bad condition and nothing else could be done. I think that the biggest merit of the edge-to-edge technique is that is the basis for the percutaneous edge-to-edge approach. Actually, the percutaneous edge-to-edge approach with the mitral clip is based on the principle of the edge-to-edge procedure. Actually, it's a replication of the surgical edge-to-edge. A few years ago, we wrote an article on the Journal of Cardiac Surgery defining the role of the edge-to-edge repair in the surgical treatment of mitral regurgitation. This article has been based on many articles which have been written by ourselves and our group in the University Hospital of Milano, and on many articles which have been published by many other groups around the world. I can show you some of these articles here in this slide, but certainly there are many more articles dealing with the edge-to-edge repair. So I would like to stress the current indications for the edge-to-edge repair. The segmental anterior leaflet prolapse is certainly a very good indication, and probably you are going to see one of these cases today during live surgery. Then we have a bileaflet prolapse facing segments. In the Barlow's disease, when you have prolapse involving segments which are facing each other, for instance, A2P2 or A3P3, then this can be a very good solution. It is also a very good solution for commissure prolapse, for functional mitral regurgitation, and this topic will be covered by Michele. There are other situations where this can be very useful, can be in some systolic anterior movement, can be in obstructive cardiomyopathy, in some complex congenital heart disease, in atrioventricular canals and so on, and also in some particular spatial situation as a rischio with severe left ventricular function, then you want to be very fast in your surgery, when the vision is not good, when you have to do it transaortically or transventricularly, in some special circumstances, this technique can be very useful. I'm going to present you some of our experience in segmental anterior leaflet prolapse and in bileaflet prolapse, and also in some riskier situation like some. Here you have in a situation, you have an A2 prolapse. You see here the jet which is directed posteriorly, which is very typical for A2 prolapse. And here is the operative view. You see here the anterior leaflet, and you can appreciate very well the chordal rupture here, which is producing the flail of the leaflet. Now, this is generally speaking, a rather complex valve. You know, it's a myxomatous degeneration of the valve with anterior leaflet prolapse. And the anterior leaflet prolapse is considered a difficult one to have a very good, reliable results with the long-term durability. This was treated, in this case, in a very simple manner. I think that the beauty of this technique is the simplicity. Simply you put a stitch here on the left side of the chorda. You see here the chorda, the ruptured chorda. You put a stitch there. You connect this stitch on the posterior leaflet, and with the other stitch again on the right side of the chorda here. No, and again you connect this on the posterior leaflet. You know, it's and with this very simple maneuver, the problem is completely solved. There's nothing else to do. It's just a 5 minutes operation. And then, of course, as I told you before, it's important to add an annuloplasty to diminish the stress on the various structures of the valve, and to stabilize, we like to use this word, to stabilize the repair. So the annuloplasty is given higher chances of long-term durability. And here is the waterproof. You inject water under pressure, like a saline under pressure, and you see that the valve is perfectly competent. And this is really, as I just wanted to show you, the simplicity of this technique for this rather complex situation. We have been able to have to demonstrate and to document similar long-term results of mitral valve repair for anterior compared with posterior leaflet prolapse. And this is an important achievement. You see here in the freedom from reoperation on the vertical axis, posterior leaflet and anterior leaflet prolapse, the p-value is 0.37. So there is no difference in result from anterior and posterior leaflet prolapse. And this is the first time that that has been demonstrating using the edge-to-edge technique, because all the literature in the past has been showing exactly the opposite. When you have a posterior leaflet prolapse, you have a freedom from reoperation, which is very high. When you have the anterior leaflet prolapse, you see that the freedom from reoperation is much lower. So I have to say that the edge-to-edge technique has been able to neutralize the anterior leaflet prolapse as an incremental risk factors for reoperation, for suboptimal results. So this is really the merit of the edge-to-edge technique. Also at the Mayo Clinic, these are very important data. Reoperation rate is here. You see that anterior leaflet prolapse is associated with higher rate of reoperation compared with the posterior leaflet prolapse. So also in this series of the Mayo Clinic, the anterior leaflet prolapse is associated with worse result, but with the edge-to-edge technique, we have been able to have similar result between the two groups of patients. And here also at the Cleveland Clinic, you have overall excellent results, but again, you can see the difference, a remarkable difference. This is the p-value between the anterior and posterior leaflet, and better results with the posterior. But fortunately, with the edge-to-edge technique, now the results can be considered equal in the two groups of patients, those with the anterior leaflet prolapse and those with the posterior leaflet prolapse. Also here is the Tyrone David series. Again, you can see very well that freedom from reoperation was much lower in patients with the anterior leaflet prolapse compared with the posterior leaflet prolapse. Again, confirming what I just said to you before. Let's have a look now in the bileaflet prolapse. These are really very bad valves, the so-called Barlow's diseases, you know, the total myxomatous, global myxomatous degeneration of the valves. The valves are thickened, the leaflets are redundant, the chordae are elongated. We are using for this type of very bad valves a very simple operation, and this again what is typical of these techniques is the simplicity. I'm going to show you a case now of Barlow's disease, which has been treated simply approximating the anterior and the posterior leaflet, the central part of the anterior and posterior leaflet. In other words, A2 and P2 with the simple sutures. So I'm going to show you this Barlow's disease, which you see very typical redundancy of the leaflets. We treated these patients in a very simple manner, just connecting A2 and P2 with a suture. And the suture is, you see here the elongation of the chorda, can be very well demonstrated. And the suture is placed far away from the free edge, about 1 centimeter away. And you see the valve is left with 2 orifices, but we complete the procedure just connecting A2 and P2. You see just with 1 simple stitches, the valve is already competent. Now we complete the procedure connecting and suturing together A2 and P2. We use a matrix suture and then an over and over suture to do that, and for sure this is going to be a stable correction. I'm going to show you that the 2 orifices here are more than enough for a proper flow of through the valve. You see that 2 Hagar's dilators have been number 20. Each one have been inserted, and then again a ring is a prosthetic ring is implanted here, and you see that after the operation there is no insufficiency at all. This operation is particularly convenient in mini thoracotomy due to its simplicity. Just a very small incision there can be associated with excellent results. We have been recently reviewing 100 consecutive patients which have been treated with this technique. The mean follow-up is 5.5 years. You see here, survival 99%. You have to consider that most of these patients are young patients. Freedom from reoperation in this consecutive series of 100 patients was 100%. There is only 1 patient only had a mitral regurgitation more than equal or more than 3+, and only 4 patients had 2+ mitral regurgitation at 5 years. So really absolutely excellent results treated with mini thoracotomy. Let me talk a little bit about the sum, because the sum is actually a risk after mitral valve repair. And there are some conditions favoring sum. First of all, is the so-called mitral aortic angle, which is the angle between this plan and this one. If this angle is narrower than normal, then you have the risk of postoperative sum, systolic anterior movement, obstructing the left ventricular outflow tract. Another possibility, when the left ventricle is small, the left ventricular cavity is very small, then the valve can be between the aorta and the cavity, and then is obstructing. Another reason can be when the posterior leaflet is very much represented. You see it's a very huge posterior leaflet, then the valve tissue can make an obstruction in the left ventricular outflow tract. And this is certainly a problem. It is important that the coaptation of the 2 leaflets should be in the inflow portion of the left ventricle, not in the outflow portion of the left ventricle. So this is a potential complication of the mitral valve repair, and we have to be very careful with this complication. We have to remove excess posterior leaflet tissue, or we have to use a large ring to avoid this problem. The edge-to-edge technique, this is the, we can remove with the sliding plastic, you can remove the posterior leaflet tissue, but sometimes it's not enough and you still have some. And our technique has been very useful to correct some. You see here at the Cleveland Clinic, the edge-to-edge technique has been very effective in correcting this complication. It has been used in these cases as a rescue operation. This is another experience. You see here, like the SAM obstructing the left ventricular outflow tract. After the edge-to-edge technique, you see that the left ventricular outflow tract is totally free, and the coaptation of the two leaflet is in the inflow portion of the left ventricle. This is a very important concept. And recently, Larry Cohn in Boston, this is a paper which has been presented just 1 month ago, I think it came out on the journal, the edge-to-edge repair used for prevention and treatment of mitral valve systolic anterior motion. And sometime Larry Cohn in Boston is using the edge-to-edge technique even prophylactically, even before coming out of bypass and seeing that then the SAM is present. I would like to finish telling you some controversial issues in regard to the edge-to-edge technique. This is a technique which is controversial, has been criticized by many because of these issues. First, the durability. This is a valve who has a configuration which is different from a normal valve. So should this valve be durable? Is durable as another valve? I want to show you an example of a double orifice, natural double orifice mitral valve, because you have to think that the double orifice mitral valve can be a congenital malformation per se. It's a malformation, but the valve can be long-lasting. For instance, in this particular patient was a 77 years old patient who was from birth to 77 years was well. Then at a certain point he had chordal rupture and he was operated. But we have to think that he was living 77 years with a natural double orifice mitral valve. So certainly we have to tell that the double orifice mitral valve can be durable, can be associated with durability, with the normal life. So this particular case had a chordal rupture at 77, but for the rest of his life, he had a good valve. Another point that I want to make, I want to show you the durability in our experience of this valve. We looked at patients which has been operated earlier in our experience, and we have now 151 patients which have been followed up for now a little bit more than that, but these are the 13 years results. And you see there was freedom from cardiac death, 95% at 13 years. And here freedom from reoperation was again almost 92% at 13 years. And freedom from reoperation and mitral regurgitation 3 plus or plus was 85.1. More recently, Michele De Bonis has been presented at the ATS our result with this technique up to 17 years. And you can read it here that the results are freedom from reoperation at 14 years was 89%. And if you combine reoperation or 3 plus mitral regurgitation, freedom was 85%. And these type of results have never been published with the other classical techniques. So we can really say that in this time frame, the durability of the edge-to-edge repair has been very well documented. 2 words on the hemodynamics. We've been checking the hemodynamics of a double orifice mitral valve together with bioengineers at the Polytechnical School of Milano. And we found with the 3-dimensional computational models, the hemodynamics are not influenced by 2 orifice configuration of the valve. And pressure gradients through the valve are related to the sum of the 2 orifices. So no matter if you have a single valve, if you have a double orifice of the same size, if you have an orifice which is double compared with the other one, doesn't matter. The important thing is the sum of the 2 orifices. And if you have a good, a reasonable amount of, a reasonable area, you can have excellent hemodynamic even with the two orifices configuration. We have been testing the physiology of the valve, putting patient on exercise. And we have a series here of about 35 patients, I think, if I recall well. They have been submitted to exercise, and you see that the heart rate goes up, the aortic pressure goes up, the cardiac output almost doubled, and physiologically, the planimetric valve area is increasing. So certainly this is, the behavior of this valve is like a normal valve. This has been a publication in France showing very well that our technique is really comparable to the type of Carpentier correction, to the classical correction in regard to function during exercise. And these data are coming directly from France, so we can really be very happy of this recognition, even in France, which is the land of Alain Carpentier. Back in 1998, so about 15 years ago, we had a kind of vision, and we thought that this type of repair, due to the simplicity of the concept, the simplicity of this concept, could open the perspective of percutaneous correction of mitral regurgitation. And this, as a matter of fact, happened, and the clip system was invented and was introduced first as an experimental tool and then in the clinical practice, and now is part of the armamentarium to correct mitral regurgitation. When should we use the clip? This is my last slide, but I think it's an important slide because when we approach mitral regurgitation in some patients, we can have patients who have old age, who can have many comorbidities, lung problems, renal problems, and so on, and they can also have severe left ventricular dysfunction, particularly patients with functional mitral regurgitation. And then, if you have old patient with comorbidities and left ventricular dysfunction, the surgical risk that you see here in red is increasing enormously, up to the point that the benefit of surgery, which is here in green at a certain point, doesn't exist anymore. This is the optimal to make your operation. But at a certain point, when the risk is too high, really the surgical risk is not to be accepted. And in these particular circumstances, in this area here, we think that there's a big role for the percutaneous edge-to-edge repair or the mitral clip procedure. Thank you very much for your attention.